open, and then when I just put in compartilhar tela, okay? Then,
yes, you can. Yes. And I'm doing the connection to YouTube too. Okay. Ok,
pode
perfecto.
fechar bem se quiser.
Ahora sí te escuchamos. Ok. Vamos a ver. Entonces, vamos a ver, acá tenemos unos en sala.
Olá. Olá?
¿Me escucha?
Sí, ahora sí.
Sí, estaba quitando el volumen del YouTube porque hay personas que se conectan por YouTube porque les es más fácil. Y es que estábamos controlando un poco la sala de espera porque la otra vez tuvimos un inconveniente. Entonces, estamos dejando entrar en sala de espera a los conocidos y si no, las demás personas los colocamos en YouTube por el temor. Aquí te mandan saludos de República Dominicana. Ok. Vamos a ver, voy a leer si alguien conoce algunos nombres. Dice Yuleisi Samboy, si alguien la conoce. Sí, ok. Randy Rosario Guerrero, no sé. Ximena, si la conozco. Sí, otra vez, ok. José Yamil Lombard, no sé qué dice. José Yamil Lombard o algo así también. Bulmaro. David Wong. Otro sí. No, no. No, que pues no. Sí, sí. Darío Sabino, sí. Una cosa. Qué cómico. Total, que ¿cómo está la situación en Brasil? Difícil.
Well, it's mejorando un poquito, but
Sí, tiene mucha, la incidencia de coronavirus que tienen es alta, ¿no?
sí, mas en São Paulo es getting un poquito mejor, mas
Mejor, okay.
que está estable en el país todo, mas en São Paulo es getting a little bit better, so I hope.
Ah, qué bueno. Sí, porque las noticias eran bárbaras, Brasil eran muchísimas, ¿no? De que había bastante.
Yeah. They like the bad news, yeah. So they keep telling the bad news all the time.
Yeah. Well, a veces no sabemos la verdad, ¿no?
Yeah.
¿Verdad? Y cuánto no. Ajá.
Yeah. ¿Cómo está en Paraguay? ¿Cómo está?
Está bien, yo ahorita estoy en Estados Unidos.
¿Estados Unidos ahora? Ok.
Pero la situación empezó bien, pero ahorita han subido, también les han subido bastante los casos. Y acá en Estados Unidos también tampoco hay un control yo no veo que haya un control tan estricto como tal. Entonces, sí, no está fácil la situación.
Mas eu estou trabalhando só. Temos os pacientes estão voltando um pouco.
Sí.
I think they get tired of not coming to the doctor, and so they ended up coming. So this week and the last 2 weeks, they have already even some surgeries, but still afraid, but better a little bit, yeah.
Okay. Y están tomando precauciones, ¿no?
Sí. Just precauciones, máscara, all the time. Yeah.
Okay. Sí, es terrible la situación, ¿no? Pero acá en Estados Unidos veo que hay bastantes, ¿no?
Hay bastante.
Tiene muchísimo, pero es que no todo el mundo toma precaución, me he dado cuenta. Sí, depende de cada zona, ¿no?
Yeah.
Bueno, Venezuela ni hablar, eso está
Yeah.
sumado a
Venezuela.
todo.
Yeah.
Muchísimos, lamentablemente tenemos muchísimos casos. Entonces,
Es un año difícil, yeah.
sí, bien difícil.
Yes.
Este año ha sido terrible,
Terrible, terrible.
terrible. Qué raro que todo el mundo sí no se ha conectado. Gracias por aceptar la invitación.
Okay.
Yo voy a dar un poquito, unos 5 minutos antes
Okay.
de comenzar para dar chance a que la gente se conecte.
So when did you go to the United States? How long have you been there?
Más o menos tengo, es que me salió los documentos, salió la residencia, entonces llegué, tengo ya un mes, exactamente un mes y pico. Ajá. Sí, tengo, sí, bueno, ahí tengo más o menos, sí, exactamente llegué el 7 de julio, tengo un poquito más. Ajá. Entonces, pero bueno, tengo que igual viajar. También sí, pero tengo igual que regresar, pues tuve que venir en vuelo humanitario porque si no perdía todos los trámites que había hecho. Y me llegó justo en COVID.
Just in COVID.
Just in COVID. And when I called in and I asked him, what can I do? How can I travel to the United States? Because all these days are closed. They told me, you don't travel, you lose everything. Everything I have to travel, whatever. Anyway, yeah, I take humanitarian, estos vuelos humanitarios. It's the only way that I can
It's
enter.
gonna get better.
But I cannot move. I cannot do anything. Only take one luggage from here. Yesterday also I received my green card. Oh,
great! Congratulations. Good.
Yeah.
So where are you? Which city are you are?
Now I came to Orlando because my brother lived here in Orlando. I was in Miami, but I came here like 1 week ago. Yeah.
Good.
Yeah. Also, I have to come back because I have everything I left everything. I have to come back again. I mean, I have to go back. But I came to fix my document, especially for the Venezuela situation, my situation in Venezuela is a little difficult. Especially if you don't agree with the government, you are.
I'm hoping for you.
You are in the blacklist. I am in the blacklist. Gracias, Ada. Tan bella. Yes, if you are in the blacklist, you are in trouble.
Well, stay away from there. Yeah. Keep
yeah, and I feel sorry for the country because the time is going worse. It's nothing. Yeah. But what about your president? Your president is a little.
Well, I mean, he talks funny, but he's acting okay. So.
Okay.
Yeah, I think it's. I don't see it. I see that he says something that he shouldn't say, but the action is straightforward. So I feel we're. I hope that he continues. I think we're going in the right direction. The interest rates are real down. It never happened. We never had these things like before. So that's very good for us. So I hope that we turn around and get better.
Some people from Argentina told me they cannot connect. I say, what? The prayer has connected? Let me check. The problem is they don't put they don't identify the
Zoom?
no, if they don't identify the dispositive or the cellular or something, I cannot see who is.
Okay.
I need to put the name. No, yeah, now we enter.
Mostly I have residents and ophthalmology. Is that what it is? Attending? Yeah. So that I can get an idea. Yeah. The colleagues from Argentina, from...
We have people from Argentina, from Santo Domingo, from Venezuela, Paraguay, Bolivia, Ecuador, Brazil. You have Brazil here, Marcela, Porto Alegre. She wrote in the chat. Don't forget Marcela. Here, look, Marcela is in the... You are from Ecuador, all the countries, South America countries, also sometimes people from Mexico too. Okay. Yes, I told from Venezuela, Caracas, specifically Asdrúbal is from Caracas, yeah. That's from many people, but anyways. Okay. I will begin. Okay, we can begin. I am going to introduce you first, okay? Okay. Bueno, buenas noches a todos. Okay. Buenas noches a todos. Esta noche tenemos un tema muy interesante. Se llama Pérdida visual en papiledema, que será editado por el doctor Mario Monteiro, a quien le agradecemos mucho la invitación y agradecemos que haya aceptado esta invitación. El doctor Mario Monteiro estudió medicina en la Escuela de Medicina en la Universidad de Sao Paulo. Hizo oftalmología en el Hospital de Clínica en la Universidad de Sao Paulo. Hizo su PhD tesis en oftalmología también en la Universidad de Sao Paulo y fue profesor libre en la Universidad de Sao Paulo. También hizo su fellowship en neurooftalmología, un primer año en la Universidad de Connecticut, en Estados Unidos, y también el segundo año en la Universidad de California en San Francisco, bajo la tutoría del doctor William Hoy. Actualmente él es profesor asociado nivel 3 en oftalmología, es jefe de servicio de neurooftalmología y órbita del Hospital de Clínica, es coordinador del programa PhD de oftalmología y es responsable del laboratorio de investigación de oftalmología, todo ello en la Universidad de Sao Paulo, en la Escuela de Medicina. El doctor ha graduado 18 estudiantes en PhD, 6 estudiantes de medicina, iniciación en ciencia, y ha sido supervisor de 6 programas postdoctorales. Actualmente tiene bajo su supervisión 5 estudiantes PhD. Publicaciones en Journal 225. Tiene 5 libros y capítulos del libro 152. El doctor Mario Monteiro tiene actividades educacionales como profesor de estudiantes de medicina, de los residentes en oftalmología y neurología y fellows en neurooftalmología en el servicio del Hospital de Clínicas de Sao Paulo y en la Universidad de Sao Paulo en la Escuela de Medicina. Ha presentado 500 conferencias y ha sido como invitado nacional e internacional. Nosotros le damos la bienvenida al doctor y le damos las gracias nuevamente por haber aceptado.
Muchas gracias. Buenas noches a todos. Me gustaría inicialmente decir que es un placer participar de este encuentro por la invitación de la Emily. Es un gusto estar con ustedes. En primer lugar, yo quiero disculparme por el español muy precario. Lamentablemente, yo tengo dificultad con el idioma. Por eso peço desculpa e empezaré hablando en español y después hablaré en inglés. La temática que elegimos, me compartir
¿Puedes compartir?
Compartilhar here.
Share, ahora.
Is it okay? No. Let me compartilhar.
Share screen.
Okay. Compartilhar. Okay?
Fantástico.
Okay. Então, a temática que elegimos é muito importante em oftalmologia, neurologia e neurocirurgia. A pérdida visual em el papiledema. Antes de falar de la pérdida visual, temos que recordar que o papiledema é o edema de papila de la hipertensão intracranial. É um sinal importante de lesões intracranianas graves. Tem implicações neurológicas e neurocirúrgicas muito importantes. Esta é a principal importância do papiledema. Pero además de la importancia diagnóstica, el papiledema también puede ser una causa importante de pérdida visual. Y también recuerde que cuando ocurre la pérdida puede haber gran confusión diagnóstica con las otras neuropatías ópticas. En esta charla nosotros vamos a hablar un poquito de la fisiopatogenia, las características clínicas, los tipos y mecanismos de pérdida visual, las causas en particular, en especial la síndrome del pseudotumor cerebral. Y yo voy a hablar de la importancia de monitorar la función visual durante el tratamiento de la hipertensión intracraniana. Nosotros devemos recordar que o papiledema é devido à transmissão da pressão intracranial, a transmissão hasta a cabeça do nervio óptico. Okay? So, tienes que abrir a transmissão da pressão para haver papiledema. Assim, observen que há uma distensão do espaço subaracnoideo perióptico em muitos casos, né? Também é importante saber que a transmissão da pressão tem que chegar até a cabeça do nervo óptico. Se nós realizamos uma ventana ou uma incisão na bainha do nervo óptico, a pressão não se transmite até o nervo óptico. Por exemplo, ver essa paciente, veja, por exemplo, essa paciente tinha edema nos dois olhos e nós fizemos a incisão na banha do nervo óptico direito e se resolveu o papiledema do lado direito, embora ela ainda tinha hipertensão intracraniana. So, a hipertensão intracraniana não se transmite até o nervo óptico, se abre uma ventana na banha do nervo óptico. Também recordar que é necessário que haja o bloqueio do fluxo axoplasmático para o desenvolvimento do papiledema. Há que ter fibras do nervo óptico e das células ganglionares para que haja el edema. Si tienes atrofia óptica, no se desarrolla el edema, mesmo que haya hipertensão intracraniana. Veja, por exemplo, este paciente que tinha glaucoma absoluto no ojo esquerdo por Sturge Weber e que desenvolveu hipertensão intracraniana. O edema ocorre apenas no ojo direito, e não há edema no ojo esquerdo. So, há que ter o bloqueio dos fluxos axoplasmáticos. A congestão venosa e as hemorragias são fenômenos secundários ao bloqueio do fluxo. So, essas considerações são importantes de lembrar. Das características clínicas do papiledema, pode ser muito discreto, bem desenvolvido, bem crônico, hemorrágico, e pode ser atrófico, como você pode ver nas figuras embaixo, com pouco de atrofia do nervo óptico. The ophthalmologist I'm sorry. I'm gonna try to move to the English so that I can think better. The classical notion is that the edema is bilateral and the vision is good. Visual acuity is normal. There's enlargement of the blind spot. There's transient visual obscuration. Also, the classical teaching is that there is headache, double vision, nausea. However, these symptoms can be very mild or even absent, and that is the basis for having confusion. So, especially in the pseudotumor cerebri, in the idiopathic intracranial hypertension, headache and other symptoms can be very mild. So that is a situation where they end up having visual loss, you know? So that's an important thing. Also, it's important to note that there are some atypical manifestations of papiledema. It can be, it's usually bilateral, but it can be very asymmetric, like, and even unilateral, you know? There's an old paper that we wrote with Dr. Hoyt, and this I mentioned the paper by Dr. Musi Mendonça long time ago, showing this occurrence, and that happened. That helps to get confusion. For example, this patient was labeled as having possible optic neuritis, but she had an intracranial pressure very high, of 30 centimeters of water. Here, two other examples. You see the patient, even with the fluorescein angiography, the papiledema can be strictly unilateral. So that's also a source of a great confusion. That's the other part. The classical teaching is that visual is preserved. However, particularly in the chronic case, visual loss may happen and may be severe. It's much more common that the visual loss be very slow and insidious. It looks like glaucoma, you know, they're losing the peripheral field. It's very uncommon that it is acute. Occasionally it can be very acute, the visual loss. And it's usually visual loss is due to dysfunction of the optic nerve, progressive atrophy of the fibers. That's the main mechanism of visual loss. There are other mechanisms too. Patients can have hemorrhages that spread to the macula, can have exudates when papiledema have too much of secondary abnormalities in the retina. So they have exudates in the macula. They can have a wrinkling of the retina that can contribute to the visual loss. They can have complications like subretinal neovascular membrane, like in this case, for example. But those are uncommon complications, but they may happen and cause great confusion. So this patient had to treat the hypertension, the intracranial hypertension, and also to have some anti-angiogenic treatment to improve the vision in the right eye. Also, patients can have subretinal hemorrhages in papiledema, like in this case. They can have choroidal folds, as you can see here. And those abnormalities, it's important to remember there is some flattening of the posterior pole of the eye, you know, because the transmission of the intracranial pressure through the perioptic space leads to a kind of hardening of the optic nerve. So the optic nerve gets stiff and kind of indent the eye. So that's why you can have this. Some patients, I have seen patients who have hyperopic shifts, you know, hypermetropia. They develop hyperoptic shift because of this flattening of the posterior pole. But the most common mechanism is the progressive atrophy of the nerve fibers. And visual field loss are very important to note. They are characteristics that you have enlarged blind spots, but that's not a main abnormality because that's due to the edema itself. It gets better when the edema resolves. But the atrophy of the nerve fibers usually manifests by inferior nasal loss, like you see in this left side here, generalized constriction that can be very severe, like you can see in this example here. I like to analyze them at the Goldman perimeter. I think it's better that you have a better idea. But again, you can have inferior nasal loss that's very, very characteristic of chronic papiledema, and generalized constriction, sometimes really severe generalized constriction. Here's is a study that we did a long time ago with 28 eyes of patients with papiledema, and 72% of them, 28 patients, and 72% of the eyes had visual field loss, and in 1 out of each 4, they had severe visual loss, as you can see in the example up here in the fields here. So visual loss in papiledema may happen in any disease, like cystic sarcosis or dilated ventricles, anything. But it's these patients, tumors, but these patients usually have other symptoms, and they usually get treated by their disease. But it's more frequent that it happens in the pseudotumor cerebri syndrome. That is a condition characterized by intracranial hypertension, and the cytology and the biochemical of CSF is normal. And there's no evidence of a mass lesion or dilated ventricles. So that's what the name that you use for pseudotumor cerebri. It can be the primary one that we will call idiopathic intracranial hypertension, or it can be, sometimes it could be triggered by some drug or some vitamin A, but most of the cases are idiopathic, no cause found. And there is a group of patients have a secondary pseudotumor cerebri, where they have problem with the venous drainage, either thrombosis of the venous sinus or some difficulties in some problem is that in venous drainage, like a dural fissure that makes the venous system hypertensive, and secondarily you can have a pseudotumor. The idiopathic intracranial hypertension is, as I said, idiopathic. It's most frequent in obese women, but it can also occur in men, non-obese, like this man, 33 years old. It was not obese and had a visual loss and headache for 6 months and had severe visual loss, So he had a normal CT and MRI. So he had to have and sometimes they take a while to check the pressure, the intracranial pressure, and they find that they do have intracranial hypertension because they had a normal neuroimaging studies, It can also occur in kids, like this 6-year-old boy that had a idiopathic intracranial hypertension. Everything was normal, and he had to be treated he had some strabismus that's secondary, but he didn't have much things. Here's an example of a secondary pseudotumor cerebri due to this patient was being treated for other causes, and MRI was normal. There was just a flattening of the posterior fold, but he had a venous superior sagittal sinus thrombosis. It was partially recanalized here. And actually, he had a hematologic disease, a problem with coagulation. So that's type of secondary pseudotumor. This is another example of a secondary pseudotumor. This patient had a cyst right near the torcula. This was a dermoid cyst. He was following this, and then he developed headache. And the cyst was pressing on the venous system, causing secondary hypertension. Was not occluded, was just creating the hypertension, okay? So this is also secondary. It's something, one thing interesting is pseudotumor is that even in the primary idiopathic intracranial hypertension, you can have secondary stenosis of the venous system. So you can have it, the pseudotumor, because of the thrombosis, because of the stenosis that is secondary to some problem or some other lesions. But even in the primary intracranial hypertension, you can have secondary stenosis of the venous sinus. So that's why there's some treatment using stents for these things. It also helps, but that's a different story. So it's important to, when you have this question of papiledema, to do a good differential. So papiledema that cause, particularly the one that causes visual loss, you have to differentiate with pseudopapiledema, with intracranial tumor, metastasis, ventricular obstruction, infectious disease, and particularly to differentiate with other diseases of the optic nerve, especially optic neuritis and other diseases, because confusion is very frequent. Like, for example, this lady was treated for a long time with corticosteroids as she had repeated optic neuritis, recurrent optic neuritis, and she had this thickened optic nerve, but the radiologist said that it could be an optic neuritis. You say, everybody, you have to be very careful not to get confused with other disease. So eventually she lost some of the visions of visual field, but she was treated correct and didn't lose any vision more. I was telling that I showed this patient before. He was treated for many months as optic neuritis. And look at his fields. He still has good central acuity and severe constriction of the field. That's not optic neuritis. That's the type of visual loss that you have with papiledema. And here's this lady. She was a fat lady, but she had some psychological problems. And because she had normal neuroimaging, she thought she was faking, or that she had pseudoedema, and she got almost completely blind because of pseudotumor cerebri. So you can have serious consequences with this. The confusions can be the other way around too. You can have bad vision because you didn't make the correct diagnosis, or you can overtreat the patient because you didn't do the correct diagnosis. For example, this girl was 17-year-old. She had headaches. She was obese, and she had this disc that they thought it was swollen. And she was treated for 3 years with acetazolamide as she had pseudotumor because she had an intracranial pressure of 23 centimeters of water. But she was obese. And there are some studies that in adolescents, intracranial pressure and children and adolescents can be higher than the normal limits, so up to 28. So it was clearly an anomalous disc. That's the old photograph that she had. The disc is exactly the same. And OCT, you can see that she had this small disc. She had a kind of a crowded small disc, and this peripapillary hyperreflective ovoid mass-like structures. It's something related. It's close to a drusen, but it's a different entity. But it's another source of confusion. She had some visual loss in the field, and she was overtreated. For example, I've seen patients doing shunt procedures, and they didn't need it, so they just had some other diagnostic confusion and some intracranial hypertension, but they didn't need it to treat that much, So the important characteristic in the papiledema is that you have the enlarged blind spots. This constriction of the field is very typical. It's also important to note that there's a relative preservation of the visual acuity. You can have a field that's very constricted, looks like glaucoma, It's not optic neuritis. The patient has like 20/20 or 20/30 or 20/25 in a really constricted field. That's typical of the papiledema, of the chronic visual loss in papiledema. Also, we have to question, because the people don't always tell us clearly that they have transient visual obscurations, like visual obscurations that last like seconds. And it's many times when standing up, everything goes dark and comes back. If you don't ask them, they don't tell you correctly, you know. So is a typical symptom too. And again, this calling attention to this relative preservation of the visual acuity. This is something that make you remember that this is a papiledema. No, even if the pressure, intracranial pressure that you measure once, sometimes you have patients that the intracranial pressure fluctuates, and in some measurements, they can have normal. They can be within normal limits, and that can also cause great confusion. In some areas, I don't know in your place, but in some areas, it's hard to get an accurate measurement of the intracranial pressure. You know, here in Sao Paulo, we have specialized laboratories that do this correctly, but many times that's not an easy thing to get. So that's something that helps to cause confusion. Okay. Another thing that helps in the diagnosis is the imaging findings. There is, as I told you, the enlargement of subarachnoidal space, like I showed here, the distension of the subarachnoidal space, the flattening of the posterior pole of the eye. And many people with this pseudotumor, with this chronic papiledema, with chronic intracranial hypertension, they have associated empty cella syndrome, partial empty cella. So these signs help you to make the diagnosis that we're dealing with a papiledema, not with other neuropathy. I would call your attention to this sign, at least in Brazil in recent years, became very popular among radiologists, okay? So sometimes they overcall this, especially like in this left side here. This patient has just a distension of the subarachnoid space, not the flattening of the globe. That sometimes you have in some normal persons, okay? So be careful with that. It's a finding that can help you in the diagnosis, but sometimes I have seen many cases that you have an overcall by the radiologist, okay? So you have to be careful with this, okay? So you have to make the correct diagnosis, particularly to clinically, and to this is for the pseudotumor cerebri, I mean, make the intracranial pressure measurement, see whether we are dealing with a primary pseudotumor or a secondary. In the cases of a secondary pseudotumor by venous sinus hypertension, then you have to do a specific treatment. You have to do anticoagulation in thrombosis for thrombosis, embolization with dural fistulas, and do a specific treatment for that. Now, when the patient has just the idiopathic intracranial hypertension, the treatment is usually clinical with weight loss in obese patients and acetazolamide in high doses of acetazolamide. And there is this treatment of venous stenting, the neuroradiologic treatment that can also help. But I usually think that this is something to as a third option in my understanding. But that sometimes there's so many good neuroradiologists around that sometimes I've seen patients doing this that I think they didn't need it yet. Oi? Olá? Não, tudo bem. Então,
No,
acho que...
it's okay. It's okay.
Okay. I was telling that the idiopathic hypertension, you do the clinical, you do the surgical treatment, could be the optic nerve sheath decompression or the lumbar shunt procedures, a lumbar peritoneal shunt or a ventricular peritoneal shunt. If you have good neurosurgeons that do that, that's a good option. And as I said, the neuroradiological treatment is also possible. But if you do the treatment early, it can cause some improvement. Like this patient had the cyst removed, just externally. It was an easy operation. It didn't have to go intracranial. They opened the skull and removed the cyst, and he got better with the papilledema, and even the fields improved. So that may happen. But if in chronic cases, long-standing cases, visual loss is irreversible. So it's very sad to see that happen, you know. So this kind of visual field loss with this atrophic optic nerve, it doesn't get better. It doesn't get better. So it's extremely important for the ophthalmologist to participate in the treatment of these patients. There's a tendency very often that the ophthalmologist say, well, that's a papilledema, this is intracranial hypertension, let's leave the neurologist do the job. It's okay if it's not a neuro-ophthalmologist, that's okay that they do that, but they have to participate with disc photographies, with visual fields, optical coherent tomography. You have to monitor the vision during the treatment. Like this patient, you see, she had idiopathic intracranial hypertension, somewhat obese. I gave her dieting. She has some visual loss, but she didn't do any treatment so far. So I start with high dose acetazolamide, and she gets a little bit better and better, and the fields remain. That's the ideal thing, you know. Now, in recent years, we have added the OCT to follow these patients. So the OCT also helps you to monitor the degree of papilledema. But it's extremely important that you use the OCT associated with the visual field, because if the disc edema reduces, you can have two options. It's either improving or it's getting worse. Both things, in both situations in papilledema, if you have decreased edema, it may mean atrophy of the nerve fibers. So that's, in this situation, it's okay, the field is stable. But in this situation, the meaning is that you're getting worse. It's different from that. So that sometimes happens. You see this patient, this is a very recent patient. The ophthalmologist, they did the correct diagnosis. She had a headache for 1 month, had this kind of visual field loss, had flattening of the posterior globe. She measured the pressure, was 23, but she started on treatment with acetazolamide. It was suggested to reduce weight loss, increase the acetazolamide, but instead of being stable and reducing the disc edema, well, she was reducing the edema in the OCT. The sequential OCT showed that she had reducing the papilledema. However, she was losing vision. So that's not a good, this is bad instead of getting better, you know? So by the time I saw her a few days ago, she was like that, severe atrophy and severe visual loss. And it was like this, you know, she couldn't even do the field. She had like 2,000 finger counting. So that shows you that you have to monitor the visual function. In this patient, she was suggested the right treatment, but it didn't work. Okay, so she should have moved it to another step, doing some kind of surgical procedure. Look at how misleading this is, how confusion can be. If you look at the OCT, you're going to say that she has good nerve fibers. Well, there's no loss here, you know. There's 111 microns in the right eye, 121 in the left. Now, that's why when you have edema, it's very hard for the OCT to pick up the nerve fiber, the fiber loss, because you may have part of the fibers damaged and the other parts swollen. So you ended up having a normal OCT like this, you know? You say, well, she's doing fine here. That's why it's important when you follow the papilledema to have macular thickness measurements too. You see these patients here, they have a disc edema here, and it looks like she has no nerve fiber layer loss, you know, because you cannot measure the nerve fiber layer correctly here. But if you look at the macula, there is thinning of the macula. So she has had some loss. She had some neural loss. We've shown that in a thesis a few years ago. So now, recently, we have the analysis of the ganglion cells. Look, for example, this patient came to me, and we thought that she had a intracranial hypertension just for a short period of time. But actually, she had this, it was already a chronic situation. She didn't have the diagnosis before, you know. She has few defects, and you look at the nerve is still swollen. But if you look at the macula, there's severe ganglion cell loss. That shows you that this is a chronic papilledema. It's a chronic disease. So that may cause confusion to you. Now, this patient was treated correctly with diet and acetazolamide, and now you can see that she got a little bit better with the fields. Now you can see that the nerve was damaged. Here you see that the nerve fiber now is 77 in the left eye. So now you see the damage, but before you couldn't see the damage because of swelling. But fortunately, the ganglion cells are about the same. So she lost vision, she lost nerve fiber layers before, lost ganglion cell layer before, but not after the treatment. That's the way that we should procedure. Another thing that's very interesting that I've been using more recently is based on the study of Cooper-Smith and Sibony and others that show that you can have some modification of the posterior pole of the eye. That's similar to what you have in the NMR, magnetic resonance imaging. But with the OCT, if you do long line scan, that can also help you to understand what's happening. As you see this patient, for example, who has papilledema here, and down below, you can see the patient with optic disc drusen. See how the contour of the optic nerve is different here. You have this contour that's kind of, you see the flattening, that's analogous to what you see in the MRI. But I think the OCT, if you do a swept source OCT or spectral domain with enhanced deep imaging and long line scan, that's the important thing. Otherwise, you don't see this you don't have this idea. You can see that there's some deformity of the optic nerve. Look at what happened with this patient after treatment. The same patient, you see the modification of the curvature of the eye, you know? So that gives you an idea of how is the intracranial pressure at that moment. As you may know, the papilledema, even if a patient comes with papilledema and you reduce the intracranial pressure right now, she takes like several weeks to disappear the edema, because the edema is caused by blockage of the fluxo exoplasmático, blocks of the exoplasmic flow, you know? So it takes a while to resolve, but this flattening may give you an idea of what's happening in that moment, you know? That's something that we're still studying a little bit. I don't think we have to be a little bit careful with this, but it may help. See another example, this same patient that I showed before had edema, and you see there's some flattening of the posterior pole, and then she gets a little bit better. There's some improvement of the posterior pole. And now when you compare the beginning and after treatment, how different she is. I don't use that isolated, but as an additional analysis, it's important. See, for example, this patient that came to me, she was a poor girl that she had severe visual loss. She had the diagnosis of intracranial hypertension. She was under treatment, but it seemed that she had resolved. There's no disc edema anymore. But she kept saying, well, my vision looks worse and I still have some transient visual obscuration. So then what I did is the OCT, see how it is suspicious, She doesn't have swelling because she doesn't have much fibers to swell. So, but if you look at the contour of the disc of the globe, you see that's very suspicious. Then I did a measurement of intracranial pressure. It was very high, and I proceeded the investigation. She had a dural fistula that was causing a secondary pseudotumor, and she was treated. And now you see that she's better. You see the modification of the posterior pole of the eye, and now you see that even this 78 microns of the right eye that you see here was still swollen here. You thought that there was no swelling, but there was a swelling. Now the normal thing for her is 64. So that's it's an analysis that you can do to help you too. Okay, so make the diagnosis of that's papiledema. Check for the cause. If it is pseudotumor, treat correctly, but follow the patient with a complete ophthalmic examination with fields, photography. It's important that the ophthalmologist participate in the treatment, okay? Now, if the patient, despite medical treatment, despite adequate treatment for the intracranial pressure, intracranial hypertension, still is getting visual loss, then he can have the surgical treatment. And then again, the ophthalmologist can help with one of the procedures, one of the alternatives. I think it's a good alternative, particularly for patients who don't have much complaints of headaches and everything. They just have the problem is many patients with idiopathic intracranial hypertension, they are fine. They are not complaining anymore of headache. They have had headache in the beginning, but then they are okay. But their problems is to lose vision, and then you can go to the optic nerve sheath fenestration, which is basically an opening of the sheath of the optic nerve to prevent from the intracranial pressure to get to the optic disc. It was described by the Vector with a rudimentary technique, but it came again after the studies of Hyre in 64 that about the pathogenesis of papiledema. That what I told you before, that was based on the studies of Hyre a long time ago. And in 73, Graubart and Survey introduced this technique in clinical use. It can also be, and created a ventana, a window in the vena of the optic nerve. It can also be made through a lateral optotomy, through the lateral to the canthus, and through the palpebra, so to the leads medially. So those are the options. I usually use the surgery described by Galbraith, the surgery with a modification of Sergot et al. That we just do some incisions, 2 or 3 incisions, like 4 millimeters or 4 to 5 millimeters in the optic nerve sheets, So that's an example of the surgery. I'm taking a video, very quick video, that you do a incision in the conjunctiva 180 degrees, and you pass some fuse in the inferior and superior rectors, and you pass some stitches in the original incision, original insertion of the medial rectors, and then you rotate the eye laterally. I don't think you can see it. You're gonna see it better, but you just go with a stab and inside the optic nerve, and then use a scissor. I'm gonna show you better in another. I'm talking together with the. Look at this. You put in a hook under the optic nerve sheet, inside the optic nerve sheet, and do like 2 or 3 incisions. Here's an older video, but it shows you better. You rotate the eye laterally, retracting the inferior and the superior rectors, and with the Q-tips, you expose the optic nerve and make an incision in the optic nerve. It's not a hard, sometimes it can be difficult depending on the orbit, and then you use this scissors that you use for ENT scissors, and you make you extend the cut of here. I'm doing a second incision and showing between one and the other incision, and this is another way of doing. I'm not using with this technique. Doing through the superior lid. Okay, it's also used by some surgeons. I think it's harder this way, but I've never done actually. And here's an example of patient. This is a patient had what we call fulminating pseudotumor cerebri. Was like a 20 years old girl. She was pregnant and she had headache for 10 days and severe visual loss. That's an exception. This is an example of an acute visual loss. This patient really confuses you with optic neuritis. She had no light perception in one eye and 20/40 in the other eye. And she had like 85, extremely high intracranial pressure. But she was pregnant. It was difficult for her to take the acetazolamide and even to do any shunting procedure. So we did some optic nerve sheet fenestration bilateral, and she fortunately got a little bit better in one of the eyes. The no light perception eye remained no light perception. Just the eye that saw got a little bit. That's one indication for the surgery: acute visual loss and recent visual loss. But most of the cases that I use this surgery is when the patient is getting worse despite the medical treatment. Okay, for example, this man, he had headaches for some months, had transient visual obscuration, started getting visual loss. Nobody knew what was happening. He was a thin, a delgado guy. He was not fat. And he came to me, he had like this. I said, well, neuroimaging studies were normal, MRI. And then I said, well, this has to be pseudotumor. And she had very high intracranial pressure. And we found out that he had a venous thrombosis that was many months before. And he had a kind of an hematological disease too. So he was started on anticoagulants and acetazolamide, but despite the treatment, because the venous thrombosis was not recent, he remained with the intracranial pressure high, okay? So despite medical treatment, he persisted with the papiledema and getting a little bit worse. So then I did the optic nerve sheet fenestration right here, and then he got better of the disc edema, and visual field got a little bit better in the left eye and stayed the same in the right. This picture here is kind of that's impression that's a little bit lighter here, but it's the same thing, you know? So you see how interesting, he remained with elevated intracranial pressure because of this chronic condition, intracranial pressure, but he's fine and vision is protected. So that's a good option for this patient, you know? here as example, a patient with visual loss despite medical treatment, so you do the sheet fenestration and helps to control. Here's a series that I did a long time ago from like 24 cases in the 90s. And I fortunately didn't have much complications. So people did fine and vision and resolve the papiledema, but it doesn't recover visual loss that's chronic, okay? It's just prevent further visual loss. Sometimes you have some recovery, but that's important to keep in mind. I think this is another study that showed also this, that visual acuity is stabilized or improved in 94% of cases. That depends very much on the type of patient that you operate. If you operate a patient with long-standing damage of the optic nerve, vision doesn't improve. But if you do a person more earlier, they get better. Occasionally, if you do a unilateral procedure, it may contribute to the other eye to improve too, okay? So that's an option of treatment. And I'm telling this because this is something that the ophthalmologist also helps to participate in the treatment of this chronic papiledema. I think this is a good option, surgical treatment, when you have failure of the medical treatment, but you still have fibers to monitor, you know? So this is a good example. Patient had edema, but she doesn't have much atrophy. So I can follow the patient afterwards. The patient that I showed before, the same thing. I can keep following the patient. If he gets edema again, I know that the surgery is not functioning. So this type of, I don't like it very much to do like this girl that I ended up having to do, because she has so much damage that's hard for us to evaluate whether the surgery is functioning. Okay, in this case, I did the surgery because it was a dramatic, like 10 days ago, and where it's you see, she was following this thing. She still had intracranial pressure very high, and then I did the surgery. You see, there's some improvement of the flattening of the eye just a few days after surgery. So that makes me feel better that the surgery is functioning. But again, this kind of patient with severe visual loss, sometimes it would be better to do a shunt procedure, in my opinion, because you feel more relieved to not to depend only on the optic nerve sheet fenestration. So that concludes our talk, where I wanted to briefly review the mechanism of the papiledema and call attention that papiledema with visual loss can cause visual loss, particularly in the pseudotumor. When it does cause visual loss, it can cause great diagnostic confusion. It can lead to severe damage and irreversible damage. And this patient should be treated aggressively. The ophthalmologist should participate with this and tell you that you should pursue the correct diagnosis. And important that you should treat the patient, but monitor correctly the visual, the edema and the visual function during treatment, okay? So that's it, Emily. If you have any questions, that's what I wanna tell you, okay?
Gracias por la hermosa presentación. Sí, aquí tienes unas preguntas. A ver, dice, bueno, Aide Martínez dice, hello Mario, a pleasure to hear you.
Hello, yeah, good to see.
Marcela pregunta, ¿cuál es la dosis máxima que da?
Entonces, en el estudio in the American study, they use up to 4 grams of acetazolamide, but I usually go up to 2 grams. You know, I usually start with a high dose, get the edema down, and then I reduce the dose. You know, I tend to do. Not always that. It depends very much on the how worried I am. You know, some people have some Papiledema, but they don't have visual field loss, just mild visual field loss. They're still obese. So I say, well, go dieting. And then I start with not such a high dose, you know. But if it's something with visual loss, I tend to go like 4 drops a day, and then I go to 6 drops a day, so, like 1.5 grams, and then occasionally I go up to 2 grams and get the papiledema better. And then I reduce gradually. Okay, every time I reduce it, I wait like 2 or 3 weeks to see if it's better. You know, then because if you reduce now, like, put in another way, saying it differently. What you see in the moment, you see, you give the Diamox now. That's one important point. You have to wait like 3 weeks to see the effect, 3 or 4 weeks, okay? That's very common. You give the Diamox, patients feel better, the vision is not having transient obscuration, but the papiledema is still there. Sometimes I see that flattening, that curve of the eye may help me, okay, to see that the pressure is really down at that moment. Because as we said before, the edema takes a while to reduce, you know, takes a while to go away. But it depends also how much they tolerate, you know. So I try to push on the maximum. It's funny that the patient have similar complaint with a low dose or a high dose. That's a funny thing. Sometimes they complain with 500 milligrams, about the same that they complain with 1.5, you know. So it's funny, this thing doesn't have a direct correlation, I think, at least in this kind of dose, you know.
¿Y por cuánto tiempo la usas? Pregunta Ximena. Ya voy a la pregunta de Aide, pero ya que estamos en el mismo...
I think it's sometimes Bill used to play with us, say that somebody used to say that it looks like intracranial glaucoma. So it does look like it's just like glaucoma. You have to give the treatment and see what's happening. You know, some neurologists tend to keep doing lumbar punctures. That's one way, but that's not the best way, you know, because intracranial pressure fluctuates that much. So if you have the OCT, you have the photographs, and you have the fields, good fields, you have everything to see whether it's functioning. So I tend to treat for many months, okay? Then I slowly taper and check whether the disease went away, you know? So sometimes the disease goes away by itself after a while, okay?
Okay. Aide has a question, the same question. Do you believe that in patients with severe visual loss and severe papiledema, corticosteroids has a place in the initial treatment, of course, associated with acetazolamide?
Well, I have done that occasionally, but I don't think it works that much, you know. So that's something that we took it from the swollen disc, you know. They give corticosteroids. It's swollen brain, you know, swollen brain in trauma and other conditions. But in pseudotumor, some people do that. I've done before, but I try not to do it anymore, you know. I try, if I'm very worried, you know, like this girl that I did like 10 days ago, what I'm doing, I did the optic nerve sheath fenestration, and I'm asking her to do repeated lumbar puncture, repeated lumbar puncture, draining with a thick needle. And we have a good laboratory here. So that's a treatment that we don't mention anymore, but some people used to do it in the past, do like twice a week lumbar puncture and draining the fluid, you know. So answering Heide, if it's a very acute, you could use that transiently, but so that you don't need to rush into the shunt procedure. So they have some time to treat the disease, okay? But corticosteroids I tend not to use, okay?
Okay. You have a message here in In Portuguese, I don't speak Portuguese.
Okay.
Sorry, Ernesto, pero I don't speak. Dice, parabéns, Dr. Mario, adorei mesmo. I don't know if I pronounce well.
Gracias,
But
gracias.
Muito obrigado. You have a question here in the YouTube. They asking here, el seguimiento con campos visuales, ¿cada cuánto tiempo lo solicita? When the visual field, how, you know.
Then again, it depends on the situation. You know, if you're very worried, you tend to do it. If it's a patient with an important visual loss, a severe papiledema, I find it nice to check like in 3 or 4 weeks, you know, to repeat the things. But usually it's more the follow-up is not so close, you know. It doesn't modify that soon, you know. So I don't have a precise answer, you see, for that. It varies depending on the patient. Again, it looks like glaucoma. If you're very worried, you do more examination until you're sure that the disease is under control, you know.
Okay. I asking you, repeat lumbar puncture are useful?
Yeah, as I said, repeated lumbar puncture, you could use that. It's something that's hard for a patient to use for a long time. But in the short time, like as I showed you, the fulminating papiledema, that lady was pregnant, was in the Hospital das Clínicas, and I scheduled her to do the optic nerve sheath fenestration like in a few days. I didn't do in the same day, but I said, well, please do me a lumbar puncture so that I can feel relieved, you know. So she did a few. So in this patient that I did last week, I'm doing again until I get secure that she got a little bit better, and probably she had this OCT with normal fibers, but she's gonna ended up having very low fibers. And then I'm gonna stop the repeated lumbar puncture and slowly removing the acetazolamide, you know. So I do the opposite. I go ahead of the disease and then I taper down. Okay.
Dr. Asdrubal Moreno want to do a question. Go ahead, Asdrubal.
Thank you, Dr. Monteiro, for your amazing talk. I have a question regarding the use of acetazolamide. Are you cautious on the reports on aplastic anemia and like Steven Johnson syndrome?
Well, I'm not. I mean, I think those complications can. Steven Johnson could happen anyway. It's a kind of a. I see. I think they are unusual. It could occur in any medications. You know, I think the question arises very often with the kidney stones, but still, I don't see that complication very often. It's a risk that you're taking, okay? But you're having the medication because the patient has a problem. So I advise them very soon to get weight loss, okay? So that's something that's gonna help you. That's an important point. If they lose like 10% of what they have before, when there is the association, that makes a difference, okay? So I try to push them to reduce weight and give the acetazolamide, and then as soon as I can, I remove it. You know, I would say that I know about it, but I think they have to take something. It's better. It's still better than you rushing for a shunt procedure. They may not need it. You know, they may reduce the weight and get rid of the disease. So anything is difficult. People tend to have this shunting procedures. I mean, neuroradiology, they think it's a simple. It's a simple. No, it's something that's feasible. But I think it's tough to live with that. You know, so I tend to. I think taking the acetazolamide is much less risk than this other procedure. Even the optic nerve sheath fenestration, I don't do that very often. You know, most of the people I can control medically. It's exactly like glaucoma. If you treat them correctly, you don't need to do a trabeculotomy, you know?
Yes. Do
Okay.
you see both sides at the same time in the optic nerve penetration? Or do
Yes.
you do optic nerve penetration in both eyes or only in one?
Yes, in the beginning when I started, I was very afraid of that. So
Okay.
I tended to do it one eye, but now I do in both eyes, unless something goes, I mean, very difficult, and but usually I do in both sides. Okay.
Me too. Okay, I used to do both. Dr. Ede dice, which are the more frequently etiology that you see in children?
Yeah, funny. In children, you don't find etiology. You know that boy that it's a funny disease. They're not associated very much with obesity. You're saying that children, you're obligated to rule out vein occlusion like otitis and patients who have infections in the ear. So that's something that you have to rule out. But when children have the idiopathic intracranial hypertension, it's very often that they are not obese. So it's the relationship with obesity is not so high. And it's a funny disease. You see that boy that I showed you, he was a nice boy, little boy, like 6-year-old, but I could do fields with him. He was a severe Papiledema. He had developed some strabismus, got some confusion in the beginning, but then I treated him like, let's say 1 year, I think. But then I removed the Diamox and never came back, you know. So it's funny thing. I had other like this, you know. Even in adults, sometimes the disease goes away and you don't understand what's happening. Some patients get chronic, you know. They come and go, but very often it goes away after a few years, you know.
Ok. Marcela pregunta si tiene cálculos renales antes de dar azotazolamida, ¿puede causar crisis renal?
Oh, I didn't have. It could cause. It could cause, but it's not so frequent as I thought before. You know, I can, maybe I had 1 or 2 patients who had it, but it's not. I thought it would be in the beginning when I was trained in ophthalmology. We used to use Diamox just for glaucoma, you know. So I had a worse idea of Diamox than what it is actually. One thing that's interesting that I had another day, just once, it was a myopic shift, a patient who had like a rotation of that's a curious thing. I didn't publish it, but it's already reported. I was so scared. The patient had this thing. It told me, well, I got severe visual loss bilateral, but I can see it near. And she came to me, and the anterior chamber was swallow. She had a rotation of the ciliary muscle. I had this once, you know, so that one I removed it. It's reported like topiramate does this effect. That's a curiosity, but most of the patients tolerate well, in my experience, if I push them, you know, to use it.
Dr. Dario Sabino, we have more questions here, but Dr. Dario Sabino want to ask you a question.
I enjoyed your talk, but I am involved in my hospital in Hospital Vargas in Caracas, Venezuela, and I'm started to perform optic nerve sheath fenestration. And one of the things that I have seen is I feel that you are right. You have to study well your patient, and you treat your patient to the time when you decided to do the fenestration. But what is happening to me is that I have the help of Dr. Musi, and he told me when he feels is the right time to do it. And sometimes we have problems because in the study of the patient, we saw that patient who has a thrombosis of the sinus, sagittal sinus, these patients, they don't behave very well if you don't treat it first with the fenestration. For that reason, the thing that you talk about, the childs don't always have meningitis and they have thrombosis of the sagittal sinus, you have to do it earlier, the fenestration. My question to you is, I have seen the changing of the methodology to do the surgery. And nowadays they used to take a piece of the dura mater that are covering the optic nerves. I feel that that part is not so easy to do it. At the beginning, we started to do only the fenestration. Now we have a punch and we make 2 holes in the dura. But in United States, I had the chance to spend a few months there. I saw that they took a very big piece of the dura and they send it to the pathologist. What is the way that you perform the fenestration? This is my question.
No, I thank you for the question. So the comment, I think you in your question, there's some implication. Let's say the thrombosis, it tends to be worse. I agree, you know, so the patients with venous thrombosis, they tend to have worse pseudotumor kind. It's more frequently associated with visual loss. I don't know what you mean, but I don't, I mean, you might use the surgery earlier, but if they do anticoagulation soon too, they can do well too. So I don't think it's you can make a direct correlation with the fact of being thrombosis or doing the surgery early. So I think it depends on the case, you know. So now
I have seen, excuse me, I have seen some report that they put some stents in the area of the thrombosis.
No, sure, but that's I mentioned to you that people are doing it's usually not when there's thrombosis, when there's narrowing of the sinus.
Narrowing.
No, narrowing, they tend to do it, and that's because these neuroradiologists are spreading around. Sometimes they do these things in other areas of the brain. So there's a lot of people who can do it, and what I see sometimes is doing without needing it too much, you know. So I mean, the other way around, the patient is not a indication. Now, I feel that the stenting would be a third option, in my opinion, you know. So in some places, like in France, in some areas of France, they do the opposite. They do the stent first, you know. But I don't feel that that's the best way. That's my opinion. Okay, I think that the patient who has doing medical treatment is losing vision, but still has nerve to follow this and don't have much headache. That's very common for me. I don't know if that's a bias for my clinic, you know, but I think the fenestration is an option. It's a good option. If the patient has real bad vision, like, and very high pressure, headaches, I think the shunting procedure is better, you know? And I have had patients who had done both, because the shunts can also fail. And when they fail, they lose vision fast, you know, it's worse. I mean, I had some patients who had the shunts. And also one thing that's important, the shunt is not an easy surgery. If you do a lumboperitoneal shunting, it's not every surgeon that does it. It's a tough surgery. And if you do a ventricular peritoneal, you also have to be good because they have small ventricles. You have to do endoscopy, and it's not that easy, you know. Many times people do the shunt and it's not functioning. And I've seen that too. So it's a big problem. I would say that most of the patients, I treat them clinically. In the Hospital das Clínicas here, we have some real bad cases that come and we have to do the surgery. But in my private clinic, most of the patients I can manage. I don't receive that late, you know.
Okay. This has another question about Ada Corona asked you, It's coming in my private. Yeah, right, doctor. What do you use in patients with sickle cells in whom the acetazolamide is contraindicated?
Well, good question. I've had some patients who had contraindication, and I tried Lasix, okay, furosemide. I used that as an alternative, but I have a few. I had one patient who had this definite history of kidney stones, and I avoided the acetazolamide, and I used it furosemide. I think it works too, so I've used that, but not many, not many.
Okay, Dr. Musi, you want to do a question to you?
Hi,
Hi, Musi.
Mario.
Good
How
to
are
see
you?
you, Musi.
Very nice to see you again.
Very nice to see you too. So
Your
very.
talk was very comprehensive.
Oh,
I congratulate you.
thank you, thank you.
Okay.
Thank you very much, Musi. So I'm sorry because if I talk in Spanish, I cannot think too much, so I have to pay attention in the Spanish, and I got confused with my thinking, so because I know that I create lots of words when I do in Spanish, so I get words.
Fine.
So have to, sorry, thank you.
Okay.
Yeah.
Asirwa Moreno has another question. Asirwa, you want to do it or do you prefer that I read it?
Yes, I've heard that some of these obese patients struggle to lose some weight. So, what are your thoughts on bariatric surgery on these patients?
Good question. Good question. I forgot to mention it does work. That's a good question. I forgot to mention the talk, and it does work. So if it's I usually don't enter that much in the indication of bariatric surgery because but if the patient has a good indication for that, I've seen, I had one patient that's interesting that occasionally the patient has the papilledema and they don't lose vision. I remember one lady was a dentist. She was an obese patient and she had papilledema. She kept coming to me and the field was still good. And I said, lose weight, please. And she will lose weight, and the papilledema was there for many years, but every time she came back, I was scared. But then she divorced then, okay? And then afterwards, she wanted to do the bariatric surgery, and she came back. All of a sudden, the papilledema disappeared, so it was like magic. It was many years. It was a kind of a chronic situation. And and I have had other patients that did that. So I always say that it's an option, okay, for obese patient. Okay.
Mm-hmm.
So it was a husband.
Beg your pardon?
It's an option to divorce.
to divorce? No. I was telling you, she was motivated to divorce, to lose weight. She was motivated.
Yeah.
I think that
I understood.
She was happy with the condition before, maybe then she was motivated and it disappeared. Was very, very very didactic case, for me,
Thank
you very much.
Doctor Jesús Castillo pregunta, buenas noches, muchas gracias por la charla, doctores, saludos a mi querido profesor Musi. Tengo una duda, ¿se debe recomendar alguna dieta específica al paciente al indicar acetazolamida? Algunas experiencias refieren a aumentar ingestas de alimentos ricos en potasio. When the patient
That's a good question too. When I do high dose, I tend to give them slow potassium supplement, but I don't think it's very often that they need it, so nothing happened. When you have children and the pediatrician is involved, anytime you have children, the pediatrician gets involved. So they get me crazy because they keep checking the acidosis of the kids. And I think the medicine needs to have some acidosis to work. So they get so worried with this. I don't get much worried with either with the potassium. I don't say that. See, if I give you high dose, then occasionally I do some supplements, but I'm not very concerned with that, you know. I think they tolerate well. I tell them to go on a diet and say they go to your endocrinologist or something to give you a diet. I don't get involved in that, you know, in prescribing the dieting, you know.
Okay, the answer, obrigado. Aide Martínez pregunta, what about oral contraceptives and pseudotumor venous stenosis?
No, if they have a thrombosis, let's say if they have a thrombosis, every patient that comes, I do the MRI and now magnetic resonance imaging and also the venography, okay, to check whether they had thrombosis. Sometimes it's very clear that they have idiopathic, but I tend to rule out in everybody, okay? But if they have thrombosis, I send them to the hematologist, and then I'm not dealing with them alone, okay? If they have thrombosis, I don't manage by myself. Now, this stenosis that they have, no, so as Idea was asking about the contraceptive, if they have a thrombosis, the oral contraceptive could be a cause of the thrombosis, you know. Now, if they just have the primary idiopathic intracranial hypertension, we keep wondering what was the cause of that, and oral contraceptive came in as a possible cause, as many medications. But I don't think that there is a relationship, you know. Sometimes we tell them, well, stop for a while to make sure, but I think the relationship would be with the thrombosis, not with the idiopathic one, okay? So, and the stenosis that they have, I think it's secondary to the hypertension.
Okay.
When they get better with the hypertension, the stenosis get better. So it's kind of an egg and the chicken, you know, the story, which came first, you know. It's probably that hypertension came first. They did the stenosis. It's funny that they put the stent, they get better. But if I treat them and they get low intracranial pressure, they get better of the stenosis too. Okay. So I think it started with the hypertension and get the stenosis secondary and kind of accentuates, perpetuates the hypertension, you know, so.
Yeah. To say I have seen patients that resolve intracranial hypertension, stopping the oral anticonceptive, of course, with good visual acuity.
Mm-hmm.
Okay.
And
Visa comment.
Yeah, I've seen patients, yeah, it's possible. It's possible. Anytime the patient has some drugs, we tend to do this. I had some patient with like something for depression. Well, maybe that was the cause, and it's always come to mind that, you know. So that's why there's such a long list of medications associated, but they're difficult to make a definite relationship.
Yeah.
My opinion.
Yes.
Well, you all have the experience. Everybody has. It's a funny disease, you know. So.
Well, I think we don't have more questions. We have many great class. Thank you. You have so many congratulations. Also in YouTube, you have a lot of people in YouTube looking for you. And all people say excellent. Thank you so much, doctor.
Thank you. It was a pleasure. Thank you.
Thank you, Mario, for with us.
Good to see you.
We hope
See you all. Okay.
Just with us again. Thank you so much. Excellent.
Chao.
Buenas noches a todos. Les envío la invitación.
Bye, Mario.
Y...
Chao, bye.
Ay, buenas noches.